For my case study, I have a patient who is a 35-year-old female with no significant past medical history. She has no family history as well, with no known autoimmune disorders. Her chief complaint is the patient presents to the neurology clinic with a 3-month history of progressive muscle weakness, which worsens throughout the day and improves with rest. She also reports double vision, which is also known as diplopia, and drooping of the left eyelid, ptosis, that worsens by evening. History of present illness. The patient first noticed intermittent eyelid drooping and mild fatigue 3 months ago, which she attributed to stress and poor sleep. Over the past month, her symptoms have worsened, and she now experiences difficulty chewing and swallowing solid foods, slurred speech in the evenings, and weakness in her arms, making it difficult to blow dry her hair. She denies sensory deficits, bowel or bladder dysfunction, or history of fevers, recent infections, or significant weight loss. When we review her symptoms, in general, she has no fever, she has night sweats, or weight loss. Neurologically, there is no numbness, tingling, or loss of consciousness. She does report diplopia and ptosis. Respiratory-wise, she's not short of breath at rest and no history of pneumonia. Musculoskeletal-wise, she has progressive weakness in the upper limbs, difficulty lifting objects, and gastrointestinal-wise, she has dysphagia to solids more than liquids, mild choking episodes as well. Upon her physical examination, she is well-nourished. She's a well-nourished female in no acute distress. She has no rashes, joint swelling, or signs of systemic infection. Neurological-wise, her cranial nerves do show ptosis, greater on the left side than the right. She has fatigability on sustained upward gaze. Doing ocular motility testing, we can see she has limited extraocular movements with diplopia on lateral gaze. There is dysarthria with nasal quality of speech. She does have mild dysphagia with prolonged swallowing time as well. Upon motor examination, we tested her strength. For her neck flexors, we noticed a 4 out of 5, which is weakness noted. Her shoulder abduction was also a 4 out of 5, which is fatigable weakness. Hand grip was normal, 5 out of 5. Hip flexors were normal, 5 out of 5. Fatigability test, there was a notable decline in upper limb strength after repetitive movement. Her reflexes were normal. They were at +2 in all extremities. Her sensation was intact to light touch and proprioception. Respiratory examination, she had a forced vital capacity of 2.5 liters, which is normal for the patient's demographics. There's no accessory muscle use and no signs of respiratory distress. Upon diagnostic tests that we ran, she did, for her lab tests, have a positive serum anti-AChR antibody, which is high in the titers side of things. She does have a serum anti-MuSK antibody negative, so she was negative for that. She also is negative on her serum anti-LRP4 antibody, and thyroid function tests did come back normal. Her CBC and CMP tests, laboratory-wise, were also normal. For electrophysiological testing, we did an RNS, which is repetitive nerve stimulation. Her decremental response in facial and proximal limb muscles was greater than 10% drop in CMAP amplitude. There was also a single fiber electromyography test, which showed increased jitter and impulse blocking. Pharmacological testing, we did the ice pack test. Ptosis improved after application of an ice pack for 2 minutes. We did a Tensilon test, which showed temporary improvement in ptosis and facial weakness. For imaging studies, her chest CT or thymus assessment had thymic hyperplasia noted, no thymoma detected. So when looking at all the evidence of her testing, it is strongly suggested that she has generalized myasthenia gravis because she is AChR positive and does have non-thymomatous. So the treatment plan that we laid out for her is we do want to do acute symptomatic management. So we recommend doing acetylcholinesterase inhibitor, which can be Meston 60 milligrams PO every 4 to 6 hours. You want to adjust the dose based on the tolerability. The max can be 480 milligrams per day. There are some side effects that do occur with this, like GI cramps, diarrhea, and bradycardia, so you do want to monitor the heart rate at all times, or just systematically as well. Then we can also do immunosuppressive therapy, so give corticosteroids like prednisone 10 milligrams a day, initially increasing to 40 to 60 milligrams a day over 2 to 4 weeks. We want to taper to alternate day dosing once symptoms do stabilize. Also, there is steroid-sparing agent, so azathioprine 50 milligrams a day, titrated to 100 to 200 milligrams a day. Alternative can be mycophenolate mofetil, 500 milligrams BID, increased to 1 gram BID if azathioprine intolerance is shown. We can do long-term disease modifications, so we want to consider thymectomy as indicated in the AChR plus MG with thymic hyperplasia. We planned for elective thymectomy in 6 months based on the age. She is less than 60 years old and she has potential for remission. When monitoring and offering supportive care, we kind of definitely want a regular neurology follow-up as well to monitor her strength, her PFTs, and medication side effects every 3 to 6 months for monitoring. As far as respiratory monitoring goes, we want to repeat forced vital capacity or NIF if worsening weakness does occur. We want to plan for rapid escalation if respiratory failure develops. We can do BiPAP or intubation in crisis. For nutritional and swallowing support, we can give a soft diet, avoid large solid chunks to prevent aspiration, and refer to speech therapy for swallowing assessment. Trigger avoidance and education is also important. We want to avoid medications that exacerbate myasthenia gravis, so like aminoglycosides, fluoroquinolones, beta blockers, and magnesium. And we want to educate the patient on signs of myasthenic crisis like dyspnea, weak cough, inability to handle secretions. Vaccination and infection prevention is important, so make sure the patient is educated on the annual influenza and pneumococcal vaccines, as well as prophylactic Bactrim if long-term immunosuppression is used. We also definitely want to plan ahead and, in worst case scenario, plan for emergency for myasthenic crisis, just in case. If she notices the red flags of increasing dyspnea or inability to speak in full sentences, or has a weak cough, we want to definitely plan that she goes immediately to the ER for evaluation for Plex or IVIG if crisis develops. As far as the prognosis and expected outcome, if she follows all these treatment recommendations with proper treatment, she is suspected that her symptom control is expected within 3 to 6 months. It's possible remission or reduced immunosuppressant requirement after the thymectomy, and we want to monitor for relapses and complications ongoingly.